Thank you, Chairperson, for your kind introduction. My name is Jung-Hwan Baek from Assam Medical Center, Seoul, Korea. It is my great honor and pleasure to discuss thyroid RF ablation for PTMC in this ACTA conference. This is my conflict of interest. Traditionally, the standard treatment modality of thyroid cancer is surgery. However, surgery has several drawbacks, especially permanent hypothyroidism is one of the major weaknesses of surgery for thyroid cancer. As we know, thyroid cancer is indolent and shows a very good prognosis. This graph shows over-treatment issue in Korea. As we can see, the thyroid cancer incidence increased steeply over the past 20 years. However, what about the thyroid cancer mortality? Mortality is unchanged. So this over-treatment issue was suggested in 2014 in NEJM. In 2015, paradigm shift from surgery to active surveillance was reported. The 2015 ATA guideline suggested active surveillance as one of the treatment tools for PTMC. This paradigm shift of ATA guideline was based on this observational trial study from Japan. After paradigm shift in Korea, we Assam Medical Center also published a paper about the active surveillance of PTMC. This is a single center study in our hospital, and then followed we performed multi-center study in Korea. The United States also performed the study of active surveillance. As the accumulation of the experience of active surveillance, we performed systematic review and meta-analysis about this issue. In this meta-analysis, we included 4 studies from Japan, Korea, and United States. In this study, we suggested primary outcomes for active surveillance. What do you think about the primary outcome for active surveillance? Cancer-related death or distant metastasis? But these outcomes are extremely rare during the follow-up of PTMC. So we suggested tumor enlargement of more than 3 mm should be one of the primary outcomes for active surveillance, and lymph node metastasis during follow-up period. We called these 2 primary outcomes as tumor progression rate. Please remember, tumor growing and lymph node metastasis are tumor progression. Let me show this graph. As you can see, tumor enlargement more than 3 millimeter is one of the tumor progression outcome. At first year, this size enlargement is only 0.1%. However, as time goes, at 5 years, it is 5.3%. This is a cumulative size enlargement of PTMC. What about lymph node metastasis? Cumulative lymph node metastasis is 1.6% at 5 years. However, there is no lymph node metastasis or distant metastasis, distant metastasis or cancer-related death. Therefore, cumulative tumor progression rate at 5 years is 0.69% in this meta-analysis. Please remember the cumulative tumor progression rate. So I summarized these clinical outcomes of active surveillance as a table like this. In this meta-analysis, 4 studies and 2,236 patients were enrolled. Cumulative tumor progression rate was 6.9%. What about summer ablation? This paper suggested some limitations of active surveillance. First limitation is delayed surgery during active surveillance. Delayed surgery is usually performed by tumor progression, size enlargement, or lymph node metastasis. However, other lesions are much larger than tumor progression rate, about 50 to 69%. What is other lesions? Other lesions are anxiety of patient and anxiety of doctors. Another limitation of active surveillance is application to young patient. This graph shows 10-year cumulative disease progression rate is much higher in young patient than old patient. Therefore, active surveillance for young patient is not acceptable so far. What about summer ablation for PTMC, RFA, microwave, and laser ablations? This table shows systematic review of summer ablations. You can see the no local tumor recurrence after summer ablation and 2 lymph node metastasis case, and the delayed surgery was performed by lymph node metastasis only. There was no delayed surgery due to anxiety. As you can see, summer ablations achieved a very excellent result. However, the thing is follow-up period. Follow-up period was too short. Recently, therefore, we performed systematic review and meta-analysis for patients with more than 5-year follow-up period. In this study, we included 3 papers, 1 from Korea, 2 from China. All studies showed more than 5-year follow-up period. When you compare the active surveillance and the meta-analysis of thermal ablation, all more than 5 years, thermal ablation shows no local tumor recurrence, no lymph node metastasis. Therefore, tumor progression rate was 0. In addition, there was no delayed surgery due to anxiety. And summer ablation is available for young patients. After our meta-analysis, one study of summer ablation more than 5-year follow-up period and one laser ablation study with a 10-year follow-up period was reported. Number of patients were around 100. In both studies, there was no local tumor recurrence, and 2% and 1.1% of lymph node metastasis. Therefore, tumor progression rate was less than 2%, and the surgery due to anxiety was one patient for each group. In both studies, the summer ablation was also applicable for young patients. Therefore, this study suggested summer ablation can overcome the limitations of active surveillance in terms of delayed surgery due to anxiety is very rare in summer ablation group, and summer ablation is also effective in young patients. Let me introduce the ultrasound changes of ablated tumor during follow-up period. This is a Korean study, a 5-year follow-up result for 84 tumors. This study shows ablated tumor increases size because we treat not only the tumor but also surrounding normal thyroid parenchyma, but ablated tumor decrease rapidly during the first year, and in most patients, the ablated tumor disappeared and remained as a scar-like lesion. This is our study. 4-year follow-up experience in Korea. 6 patients were enrolled in this study. Among 6, 4 patients showed completely disappeared treated tumor by RF ablation, and 1 patient showed decreased tumor size and remained as a scar-like lesion. We performed core needle biopsy for this lesion, and there was no tumor cells. 1 year after, that means at 5 years after RF ablation, the scar-like lesion is completely disappeared. This PTMC contains a macrocalcification like this. So we can see the macrocalcification and hypoechoic PTMC. 3 years after RF ablation, the hypoechoic tumor is completely disappeared. However, macrocalcification is remained like this. What about the T1B cancer? T1B cancer means the size of 1 to 2 centimeter. This paper from China, 14 hospitals were enrolled, and they compared T1A and T1B tumors. This is a multi-center retrospective study. This study enrolled huge patient population, about 447 patients in T1A and T1B group. The thing is short follow-up period. This study result shows they treated T1A and T1B cancers by RF ablation and microwave ablation. As you can see, only one patient for each group showed lymph node metastasis, but there was no local tumor recurrence. So they concluded thermal ablation is effective for T1B cancer. This graph shows recurrence-free survival was borderline significance in both groups. So when you compared active surveillance, T1A thermal ablation and T1B thermal ablation, you can see the active surveillance and the thermal ablation shows a similar effect, but delayed surgery due to anxiety was extremely rare in thermal ablation group. In addition, thermal ablation is applicable for young patients. In summary, I explained paradigm shift for PTMC from surgery to active surveillance. However, active surveillance showed some limitations. Many delayed surgery due to anxiety of patient and doctors, and the application of young patients are not available in active surveillance. Therefore, I introduced thermal ablation can overcome the limitations of active surveillance. So finally, I would say thermal ablation can be a potential game changer for treating PTMC. However, thermal ablation has some limitations. Small study populations and the 10-year follow-up is very rare, and cost is much higher in RF ablation, and quality of life after thermal ablation is unclear so far. Finally, let me introduce this study. This study treated 3 cases of PTMC by thermal laser ablation and then performed immediate surgery. The surgery result shows there was a complete treatment of PTMC, but some very small foci of microcancers in both thyroid lobes, and one patient shows microscopic lymph node metastasis. So they explained that laser ablation shows excellent local tumor ablation. However, tiny satellite cancers in thyroid gland and microscopic lymph node metastasis is a limitation of thermal ablation. This is our RF ablation team in Assam Medical Center. Thank you for your attention.